So in this patient we don't have to worry about the age menarche to 40 years. In this population we can give menarche to 40 years, post abortion, anemia, any iron deficiency anemia or malaria, in HIV AIDS, and gestational trophoblastic disease, neoplasia following normal HCG level, history of ectopic pregnancy, endometriosis, uterine fibroid, ovarian and endometrial cancer. In this condition we don't have to worry about giving COC. Actually in this condition we use that treatment. And in dysmenorrhea and DUB, dysfunctional uterine bleeding, in pelvic inflammatory disease, epilepsy, thyroid and tuberculosis, in varicose vein, benign breast disease, we don't have to worry about while giving oral combined oral contraceptive. And nextly we are going to discuss about contraindication of COC. In the relative contraindication we have WHO category 2, that is in them advantages is far more greater than risk. Advantages outweighs risk. That is in age greater than 40 years, greater than or equal to 40 years, in smoker less than 35 years, in patient with history of jaundice, in mild hypertension, in gallbladder disease, in diabetic patient, in sickle cell disease, in headache, in cancer cervical intraepithelial neoplasia. In WHO category 3 we have the condition where risk outweighs the advantages: unexplained vaginal bleeding, hyperlipidemia, liver tumor, breastfeeding, and heavy smoker greater than 20 cigarette per day, and past breast cancer. In this condition the risk outweighs the advantage. There is relative, in this condition there is relative contraindication. Now talking about important aspect, that is absolute contraindication of the oral combined contraceptive, and this belongs to WHO category 1, category 4. And in them we have the various conditions like circulatory disease, past or present circulatory disorder like arterial and venous thrombosis, severe hypertension, history of stroke, heart disease, valvular and ischemic heart disease, diabetes with vascular complication. In diabetes with vascular condition this is absolute contraindication, and in diabetes there is relative contraindication. And migraine with focal neurological symptom, that is aura. Migraine with aura is also absolute contraindication for combined oral contraceptive. In the disease of liver like active liver disease, jaundice, we don't use COC. In the liver adenoma and carcinoma we don't there is absolute contraindication of COC. And in pregnancy we don't use COC. Other conditions like pregnancy, breastfeeding, pregnancy, lactation, and postpartum up to 6 weeks, and major surgery or prolonged immobilization, and estrogen dependent neoplasm like breast cancer. So in this condition where there is absolute contraindication for combined oral contraceptive. So how can we prescribe? How to prescribe a pill? Firstly, there is patient we have to give patient the instruction like new users should normally start their pill packet on the day 1 of their cycle. 1 tablet is to be taken daily, preferably at bedtime for consecutive 21 days. It is continued for 21 days and then it has a 7 days break. With this routine there is contraceptive protection from the first pill. Next pack should be started on the 8th day irrespective of bleeding. Same day of the week the pill finish. The same day of the week the pill finish. Thus a simple regime of 3 weeks on and 1 week off is to be followed. So what we have to do is the simple regime of 3 weeks on and 1 week off. And packing of 20 tablets, there should be no break between the packs. 7 of the pill are dummies and they contain either iron and vitamin preparation. However, a woman can start the pill up to day 5 of the bleeding. In that case, she is as well to use a condom for the next 7 days. The pill should be started on the day after abortion. The child following childbirth in non-lactating women, it is started after 3 weeks, and in lactating women, it is withheld for 6 months. We don't give up to 6 months. Next is about follow-up. The patient should be followed up based on her symptom. The patient above the age 35 should be checked more frequently. And in case of missed pill, normally there is return of pituitary and ovarian follicular activity during the pill-free interval of 7 days. The breakthrough ovulation may occur in about 20% cases during this time. The lengthening of hormone-free interval due to omission, malabsorption, or vomiting either at the day or at the end of packet increases the risk of breakthrough ovulation and therefore pregnancy. So, if a woman forgets to take one pill, she should take the missed pill at once and continue the rest as scheduled. There is nothing to worry. But when she misses 2 pills or more, she should take the most recent missed pill immediately and then continue the rest as scheduled. Extra precaution has to be taken for next 7 days, either by using condom or by avoiding sex. Alternatively, a new pack can be started and barrier method to be used additionally for a week. Failure of withdrawal bleeding during the pill-free interval, the woman should be excluded with medical test. Common hormonal contraceptives are not teratogenic when taken accidentally in early pregnancy. Drug interaction, these oral contraceptives have many drug interactions, as we have already studied in pharmacology during our second year. The effectiveness of some drug like aspirin, oral anticoagulant, and oral hypoglycemics, lamotrigine are decreased, and that for some other drugs like beta blocker, corticosteroid, diazepam, aminophylline are increased by oral contraceptive. Additional contraception. To ensure 100% efficacy, and additional mechanical contraceptive, usually condom, are to be used in the following circumstances, like when broad spectrum antibiotic like ampicillin, ciprofloxacin, tetracycline, doxycycline are used, as they impair the absorption of ethinyl estradiol. When enzyme inducing drugs are used like barbiturate, all anti-epileptic drugs except sodium valproate and clonazepam, rifampicin, ketoconazole, griseofulvin protease inhibitor like ritonavir, nevirapine. Under these circumstances, the high dose preparation ethinyl estradiol of 50 microgram or more are to be used to counterbalance the increased liver in metabolism. So, what are the indications for withdrawal? The indication for withdrawal of pill are severe migraine, visual or speech disturbances, sudden chest pain, unexplained fainting attack or acute vertigo, severe cramp and pain in leg, excessive weight gain, severe depression prior to surgery. It should be withheld for at least 6 weeks to minimize post-operative vascular complication, and patient wanting pregnancy. Now we will talk about health benefit of combined oral contraceptive. So before that, we may have question that how long can the pill be continued? The potential benefit of pills are far greater when compared to risk in a well-selected individual. A woman who does not smoke and has no other risk factor for cardiovascular disease may continue the pill with careful monitoring until the age of 50 years. This offers the dual advantage of effective contraception and hormone replacing therapy. However, for spacing of birth, use of 3 to 5 years is considered enough and safe for pill use. So what are the health benefit of COC? Firstly, we have contraceptive benefit. As we all know, it protection against unwanted pregnancy. It is convenient to use and not in intercourse related. It is not related with intercourse. It is reversible, and it improves maternal and child health care. Non-contraceptive benefit, health benefit include it regulates the menstrual cycle. It improves the menstrual abnormalities by regulating the menstrual cycle, reduction of dysmenorrhea, reduction of menorrhagia in 50%, reduction of premenstrual syndrome, a reduction of Mittel-Schmerz syndrome, protection against iron deficiency anemia, protection against pelvic inflammatory disease, as they make cervical mucus thick. They protect against ectopic pregnancy and endometriosis. COC protect against fibroid uterus, they protect against hirsutism, acne, PCOD. They protect against functional ovarian cyst. They have a health benefit in benign breast disease, but not in breast cancer. Only in benign breast disease. In breast cancer, it is contraindicated. It is helpful in osteopenia, postmenopausal osteoporosis. It is help in autoimmune disorder of thyroid, rheumatoid arthritis. It increases the bone density, and it also prevention of malignancies, like it prevents the malignancy like endometrial cancer, epithelial ovarian cancer, and colorectal cancer. Endometrial cancer and epithelial cancer, these are mostly estrogen dependent neoplasm, and it is helpful in endometrial cancer and epithelial ovarian cancer. So what are the adverse effects of combined oral contraceptives? The minor complications are as follows. Firstly, nausea, vomiting, and headache. This is mainly due to estrogen use. Nausea, vomiting, and headache is due to estrogen, and leg cramp due to progesterone. These are transient and often subside following continuous use for 2-3 cycles. Next one is mastalgia due to both estrogen and progesterone. There is heaviness or even tenderness in the breast, which is often transient. And there is weight gain due to progesterone component. Though progesterone have got anabolic effect due to a chemical reaction to testosterone, use of low dose combined oral contraceptive does not cause any increase in weight. Next one is chloasma due to estrogen and acne due to progesterone. These are annoying for cosmetic reason. Low dose oral contraceptive improves the acne as levonorgestrel preparation are less androgenic. Second one is menstrual abnormalities. Breakthrough bleeding, it is commonly due to subthreshold blood level of hormone, and COC has the complication of like hypomenorrhea, menorrhagia, and amenorrhea. The post-pill amenorrhea of more than 6 month duration occurred in less than 1% of cases. And next one is decreased libido due to progesterone component, due to dryness of vagina. And next one is leukorrhea due to excessive cervical mucus secretion due to estrogen, or due to increased preponderance to pondylial infection, candida infection by both estrogen and progesterone. That is leukorrhea. Now we will see the major complication of combined oral contraceptive. First one is depression. Low dose estrogen preparation are not associated with depression, but high dose is associated. Hypertension due to estrogen current. Third one is vascular complication due to estrogen. Venous thromboembolism. The overall risk is to the extent of 3 to 4 times more than non-user. Pre-existing hypertension, diabetes, obesity, thrombophilias, both inherited and acquired, and elderly patient over 35, especially with smoking habit, are important risk factor. The ethinyl estradiol used with dose of 20 microgram in pill reduces the incidence. The most important risk factor is genetic thrombophilia, that is factor 5 Lydian mutation. It is rare in Asian compared to Caucasian. The lowest risk of venous thromboembolism is with COC containing LNG, NET. The increased rate of venous thromboembolism is seen with other COC like other combined hormonal contraceptives like transdermal patch and vaginal ring. Thrombosis. The high risk factor for myocardial infarction and stroke, ischemic hemorrhagic stroke, are hypertension, smoking habit, age above 35 years, and diabetes. Next is cholestatic jaundice. Susceptibility is increased in women with previous history of idiopathic recurrent jaundice. We have the neoplastic risk of breast cancer and cervical cancer. Combined oral contraceptive reduce the risk of epithelial, ovarian, and endometrial cancer, but it increases the risk for breast cancer and cervical cancer. Also, there is increased risk of hepatocellular carcinoma has been found with low dose preparation. And rarely in 1.5 out of 1 lakh population, in 1.5 population, there is the risk of death is occurs, but that is very very significantly low. So that was all about combined oral contraceptive. Now we'll see in brief about centroman, known as Saheli. It is meloxifene. It is a product, research product of Central Drug Research Institute of Lucknow, India. It is non-steroidal compound with potent anti-estrogenic and weak estrogenic property. It is taken orally 30 milligram twice a week for first 3 months, then once a week. It works primarily by inhibiting implantation of fertilized ovum. It creates asynchrony between developing zygote and endometrium, causing implantation failure. It doesn't inhibit ovulation. Its side effects are very few, and it is avoided in polycystic ovarian disease, cervical cell hyperplasia, the liver, and the kidney disease, and tuberculosis. There may be tendency of oligomenorrhea. The failure rate is about 1 to 4 per 100 women years of use. The failure rate is less with increased doses. Because of the potent anti-estrogenic activity, centroman is being currently tried in management of dysfunctional uterine bleeding, endometrial hyperplasia, endometriosis, and breast cancer. It is used as a hormone replacement therapy because of its weak estrogenic property. However, risk of venous thromboembolism is lower compared with pregnancy and puerperium. That was about syndrome and Saheli.